Well, welcome to the Meet the Fellows session at the ISV Congress. I'm really thrilled today to be interviewing one of our fellows, Dr. Gary Kobinger. My name is Margaret Liu. I'm chairman of the board of the International Society for Vaccines. As you know, ISV has a very big commitment to helping all the scientists, regardless of their background, whether they're in academia, whether they're in industry, whether they're in regulatory affairs, or whether they're at the early parts of their career or later on, to know more about our fellows so that if you did want to ask them for advice, you would know who to talk to, but also so that you get an idea of the different career pathways and how you might be developing your career. So I'm really thrilled today to be speaking to somebody who I think is actually unique within not just ISV, but in the vaccine world, because Dr. Gary Kobinger is somebody who has not only done basic research and helped to develop vaccines, but he's done the whole spectrum. So he's done the whole spectrum from doing work at the bench to resulting in a vaccine that is now licensed and is used to save many lives. But he's also been important for developing diagnostics, which are crucial for any new disease or any existing disease or pandemics and epidemics. But he goes beyond that. So beyond doing diagnostics and developing vaccines, he's actually helped to develop a therapeutic. So monoclonal antibody that has been really instrumental for the treatment of Ebola, the disease. So you all who are tuned in today have the privilege of meeting somebody who's really unique, who's really done every aspect possible that would involve infectious diseases, and as well as having done the lab to the clinic. So I'd like to turn it over now to Dr. Gary Kobinger and ask him to tell us a little bit about himself, what his career has involved, and what type of science he's been involved in within the field of vaccines. Gary?
Thank you so much, Dr. Liu. And first, thank you so much for taking the time. It's an honor for me to talk, have this chance to have this discussion with you. I've been seeing you all over and your name and when you were president of ISV. And this is a very thankful moment for me. So in terms of my own career path, I started, being convinced that vaccine was a unique tool in order to save lives, basically. It's a tool where you can multiply the benefit to people before they even get the disease or a disease. That said, it's a very challenging field. It's a difficult one also because actually for the same reason, you're trying to keep somebody that is healthy. And so the approach is different. The perception are very important. And so I'll consider it's a very comprehensive field. It's a field that is not just somebody in a lab trying to make a good vaccine. It's a field where you need to think about vaccine hesitancy, about what target population, about different things. So early on, my main motivation was actually to work to try to protect against HIV, because as a kid, I'd seen a documentary and I had seen, in this documentary, there was this individual that was saying that he was going to die because he had loved, and I thought this was unacceptable. And I thought, the vaccine was the best approach to try to solve that problem that was already worldwide in the 90s. And so I did my PhD on HIV actually, and realized, in my view, that we didn't have the tools. This virus was too formidable, and especially in terms of adaptation, for us to really make a substantial contribution. And so I focus on gene therapy because the people in the gene therapy field at the time were actually trying to avoid the immune response. And I thought by studying with them what was important in order to not trigger an immune response, I could maybe learn new tricks to stimulate that immune response, if you want. And so I ended up doing vaccine research in a gene therapy lab with Jim Wilson at the University of Pennsylvania, and I was lucky enough to convince him to start doing some vaccine project that he continued after that for years and did a great work on vaccine. And from that point where we started studying the Ebola and enveloped glycoprotein, with my background, I was already on HIV, so on at the time on biosafety level 3 pathogen, and then that spilled over on SARS, the first one, and so on. I moved to really focus on Ebola because I thought that if there's a disease where we can learn a lot in terms of vaccine development, is Ebola. And it's a great disease model for vaccinologists because it's a fast model. You can infect the animals, and in the model, they die within 10 days, which means that you can learn a lot in this kind of model, as opposed to still today, HIV, quite frankly, takes easily a year. So if you have to wait a year before you accumulate enough data to learn what's the next move to improve your strategy or even change it. So Ebola was very good for this, and taught me so much, not only again in terms of the vaccine field, but to start at the population level. What is the type of vaccine that is acceptable for them? What is their needs? Where are you going with this vaccine after that? Is it for a village? Is it for a continent? Is it for a subpopulation like healthcare workers? Is it for the world? These are all questions that are important, and this is from this perspective that I see today. For me, there's not a vaccine that fits it all. Every vaccine has its plus and minuses and should be better adapted for one application or another. Not to say that many vaccines could be applicable to one specific issue or pathogen, but this is it in a nutshell. And then I started doing the level 4 work. I started going to outbreak in Africa, doing diagnostic first, learning about the needs on vaccine, also seeing the devastation that a virus can cause. Trust me, I don't take COVID and SARS-CoV-2 lightly, but it's not what we call a dangerous pathogen. It's a high consequence pathogen. It is two different things. A dangerous pathogen that kills 35 to 90% of the people infected is a different level throughout all age groups. So Ebola was really a field where I learned a lot.
That is actually, I think, a pretty dramatic pathogen to start working with. Can you talk a little bit about then your work working with such a dangerous pathogen in the context of a BSL-4 laboratory? So how did you get comfortable working with that, and what motivates you to be daily working at that level of potential exposure to yourself? I mean, it's much more carefully modulated than, say, a physician who's caring for somebody coming into the emergency room. They don't know, what they have, but then on the other hand, you clearly went out in the field and were working where Ebola itself as a disease was being spread. So maybe can you, because we do have people in ISV who are both, bench scientists as well as people who are physicians and are treating patients. Maybe you can talk a little bit about how you balance those issues for yourself.
Yeah, and I will first say that I think that, like in every field, the approach that I learned throughout my trainings, including at the University of Pennsylvania, is work with the best in a way that you help them, and you see how you can contribute at least as much, if not more than them. That's the goal. And by collaborating with the best people, you become a lot better yourself. And so for the level 4 part, I learned with the best, in my view, Heinz Feldman. I arrived in the level 4 program, already had 15 years of experience in level 3. But more importantly, in my view, I had a very strong, robust scientific foundation that I'd learned during my PhD and my postdoc at the University of Pennsylvania with Jim Wilson, with David Weiner that I met at the time. And so, when you know the pathogen very well in every shape or form and different aspect, and you arrive in an outbreak, a natural outbreak, you can see you're more comfortable and you're more comfortable and you're more precise in how to protect yourself. Nothing is 100%, and this is what to keep in mind. And again, to not fall into the habit of all the things or think that you're better than other people. So just to to keep an open mind on the danger, but also the knowledge is always a huge factor into your safety, basically. And so I think your training is so important, and the people that are involved in your training and the people that you select as a role model, I think are also very important. And for this, there's great scientists out there, and there's great people that are there to help, specifically in the vaccine world. There's look in the vaccine field, it's extremely very high level of percentage of empathic people that they feel really in their heart that they want to help. That's their main motivation, and that's why they work long hours. Yeah.
That's actually, I think you're making an interesting point there that ties in with who you learn from and how you learn, but then how you then proceed to do your work, which is, you seem to have emphasized 2 points. The first is excellence, and the second is also great extreme care for the high quality of whatever you do that pertains both to your research, but then also to the care with which you protect yourself, for example, against these pathogens. And it seems like what you've said is that attention to always ensuring the care and the attention to detail is important for the people you learn from, but then how every single day what you do in your work contributes to the quality of your research and therefore of what you can contribute. Is that a reasonable summary of what you said?
Yes, absolutely. I fully agree with that.
So tell us a little bit more now what you've been doing though. So you were at University of Pennsylvania, and then you've been up in Canada. So tell us what your career involved during that time. You worked on Ebola from starting with HIV, and you dealt with viral vectors as well. So tell us both about the scientific development of why you picked the viral vectors to work on, but then also your new position that you're taking up starting this week with your move from Canada to the United States.
That's right. So, I'm at the University of Pennsylvania, I really learned, including using gene therapy vehicles, that some of them are very powerful to stimulate immune responses, and some others less. And with this, we learned a lot with the gene therapy side. And so I moved to Canada as an independent PI. I was recruited at the National Lab in Winnipeg, the Level 4 program, where I became the chief of the program. I think it was 3 years later, when Heinz, who was the chief, left to go to the US. And I stayed a total of 11 years. And that's really during those years that we continued the VSV vaccine that Heinz had initiated to push it through the clinical studies, phase 1, phase 2. And at the same time that the West African outbreak. At the same time, we focus on diagnostic and specifically on treatment as well. And the monoclonal antibody field at the time was really cancer and autoimmune responses. The only product that was synergist for RSV. And, at the time, I remember going before the West African outbreak to visit some colleagues that were, working hard on monoclonal antibody against cancer. And, they didn't buy so much the angle of the infectious disease, which now has completely shifted if you look at it. And using, relatively old technology of mouse monoclonal, we showed that it could work against a virus that is so fast and so virulent than Ebola. And I think now you see the same recipe being, which is not, we didn't develop that ourselves. We just, I think adapted the past concept to say, okay, let's attack the virus at different targets, 3 monoclonals instead of 1. Let's not try to prevent infection. Let's just try to keep a lid on it and let the immune response of the host take over. Let's buy time to this host and keep the viral load down. These principles are still being applied. The new treatment against Ebola are better, the new monoclonals that are human antibodies. Now the technology is exploding. COVID, you see Regeneron all over the place. The explosion of mAb treatment for infectious diseases right now, and it's phenomenal to see that. I think this is one of the most important field currently. And so from Winnipeg, I went to Quebec to be director of a research center to go back to academia. The Winnipeg is a government lab, and I wanted to see honestly if I could. Academia is a tough world, and it's when you're funded with A base, as we call it, in like the NIH structure, it's not necessarily easier, but it's different challenges. And I wanted to get back to academia. I wanted to get back to also the academic freedom. And I think I did very good in the past 5 years. And now actually I'm continuing in academia, but back to level 4. So this to me is the dream concept of being in academia, but also having access to all the tools and the environment to continue to make the best and especially support the young scientists, the mid-career scientists, everybody I can. I realize a lot of my dreams. I still have many, but one of them is actually to see the young individuals realize their dreams, is to support them and do everything I can to get them to meet their dreams in science.
Well, that's fantastic. I mean, it seems like you are passing on the experiences you have now to the next generation. Since you're such an expert on viral vectored vaccines, I think I can't pass up this opportunity to ask your thoughts about them, in particular in relation to COVID. So one of the key things that was so impressive about the Ebola vaccine that you helped to develop was that it was a one-shot vaccine. And of course, this was crucial because of the nature of Ebola and its spread. And so that was really one of the main reasons that was selected as the first candidate that then was taken through and was licensed, because it was a single dose. At the same time now, of course, there have been a lot of questions asked about viral vectors as platform technologies, in the sense of certain viral vectors are based on viruses that we all may have already encountered. And so there may be pre-existing antibody in a certain percentage of the population. But then, of course, once you've given one injection, then people will, of course, make their own immune response to a second injection. So we've seen this particularly studied now with many experimental vaccines for HIV, for example, but also now with the SARS coronavirus too, where the Johnson & Johnson vaccine is a one-shot vaccine, but they just recently provided data that a boost 8 months later gave very high antibodies that were actually a higher boost than if they gave them early on. And so that has raised the question of, well, don't they have some immune responses against the viral vector from their first shot? And how does that have an impact against using it as a booster, in addition to the fact that some people pre-existing may have antibodies against adeno 26. On the other hand, then you have a vector such as the Chaddox vaccine from the Jenner group that is a chimpanzee virus. And so the idea there was, well, people wouldn't have any pre-existing antibodies, but then they, of course, after the first shot would have antibodies. And in fact, it did seem like from some of the trials that boosting with an mRNA vaccine gave a higher boost. So my question for you is, what do you think about viral vaccine vectors in general. Clearly, you have the success of your one-shot Ebola vaccine, but then you have the other successes of these adenovector vaccines for COVID, but you still have this issue of immune responses. So do you think that viral vectors in general will be able to be used as broad platforms, or will it be better to think about maybe heterologous prime boosts so that you don't have to deal with the creation of the immune response against the vector itself?
Yeah, these are all great questions, and we have to be thankful about all the work that is being done against COVID, because we are learning in a few years, because it's continuing, on vaccinology more probably than we have ever learned, and since the history of vaccine, quite frankly. But we are reinforcing past paradigms. One of which was mainly, I think, was highly debated, let's call it that way, is from our work anyway. The time between the prime and boost is very important, and the more you wait, the better it is for the memory response. But again, it depends what you're facing. So it's back to what's the situation? What do you need to achieve? Do you need instant protection, where one dose vaccine is like Ebola because it's spreading like wildfire, or do you need to have a sustained protection that will last for 10 years? And it's okay if you take a bit more time because your first dose already provides some level of protection, which the mRNA vaccine does, and adenovirus as well. So, so the bottom line is, if you can wait, in the work that we have done, it's better to wait for a boost, including and especially for viral vectors. There's ways to bypass pre-existing immunities, but you have to use them. The first, what is being done now, whether with Simonad, that we called it initially like this, this concept of using adenovirus from non-human primates, actually, to my knowledge, was started in at the University of Pennsylvania with Jim Wilson. And the first paper on Simonad came out of the lab for Ebola, and Gundi was the first, I think, to publish from the vector that she had obtained, and she published on HIV, showing that the vaccine worked. And the point is, the initial concept is to bypass pre-existing immunity, even from the first dose. So yeah, it makes sense that if you wait more, this immunity will also go down. You'll have a better boost effect. If you go with an heterologous boost, even better in terms of this jump. The question is, when you get the boost effect, how long is it going to last? And when it settles back down, are you going to be higher than the first dose? These are important. I'll tell you why, because some vaccine platform like VSV, you can boost, but in human, what the data are, limited data, so it has to be taken with a grain of salt, but the data are that you get the boost effect, but after that, the level get back to the same level as the first dose. So is it still helpful because you're just looking at one immune parameters? Maybe, but maybe not. So it's not clear. Actually, the question of long-term protection with Ebola, with the VSV vaccine, is still a big question mark. And right now we have a study starting, clinical study starting this week, actually. So great that we are talking, is starting on September 1st, the recruitment for a boost. It's a boost study. So there'll be a second dose given to a cohort that was vaccinated 5 years ago. And we'll see what happened. So in this case, it's a heterologous boost. So it's a DNA boost over VSV. We'll see what happened again. And I think these studies are very, very important. And again, we need to focus on also learning on what are the best vaccine for immediate protection versus long-term protection, if that's required. And of course, we want it all. Us scientists, we want everything. But sometimes it's also, and it's good to continue to search that everything and that perfection. This is what's important. But it's okay in the meantime to identify what is optimal for solving the many different issues that we have, and the many case scenario in terms of infectious diseases and cancer for that matter. So yeah.
I think that the lessons to be learned from this trial you're talking about are really important because, of course, it is the titer, but it's the quality of antibodies, such as their, high affinity, but then it's also these T cell responses and both T cell help and CTL responses. But then there's also this whole issue of innate immunity. So if you don't mind, I'd like to ask you a little bit about that, because I think that in the early days, in fact, whether it was for gene therapy or whether it was for vaccines, people often thought of a vector as simply kind of like a shuttle, whether it was a Trojan horse type of delivery system where what you were really interested in was the payload. And certainly for gene therapy, that's been one of the issues, as it turns out, of course, that whether it's viral vectors, whether it's plasmid DNA, or whether it's mRNA, that all of these delivery systems have their own ways of activating the innate immune system. And sometimes that's a really good thing. And in fact, it probably is very helpful for getting the antigen-specific immune responses. Sometimes for things like gene therapy, maybe not so helpful, and maybe destroys the vector more rapidly than otherwise you would want. So what I'd like to ask you about is, what do you think the contribution is, or the importance of this innate immunity? And the reason I'm specifically asking is there's been longstanding work out of Peter Abe's group in Denmark that the WHO and many investigators have looked at, showing that children who got BCG had protection against other diseases subsequently that appeared to be related to their having gotten BCG as a protection, as a vaccine for tuberculosis. So I'd just be curious as to your thoughts about whether these innate immune responses that different viral vectors may induce differently may actually be part of a reason why certain viral vectors may have different efficacy for whatever disease they're actually targeting based on the heterologous gene, that antigen that's encoded by them.
Yeah, so I thank you. I think the innate immune response is very important to understand better too. I think to me it's a bit of a minefield at the same time. I think inflammatory response can be a good add-on, and I think they are better left untouched or avoided in some application for vaccinology as well. I mean, definitely for immune gene therapy or gene therapy in general. So this is all very important. That's why I think there's so much work and also at the same time care for people that are studying adjuvant. So it's how do you exploit the innate immune response only for the positive and without any of the negative sides. And again, it's I find the BCG observation very, very intriguing and very important also, because I do believe that it makes sense to me that that there's a way that you can go and stimulate the innate immune response in a way that will be beneficial against other infection. And better understanding this, I think is very important. Now, how much can you exploit this is a big question. But definitely the more we know about the innate immune response and how to really fine tune our stimulation of the innate immune response to really have only the benefits of an innate reaction versus, risk, allergic reaction or risk, other unwanted side effect or manifestation of that stimulation is critically important.
So thank you. What I'd like to do just to close out this interview is to ask for your thoughts, your advice that you might give to people who are in the field of vaccines to see how, from your experiences, you've been in the field actually, dealing with the actual disease itself. You've been in high containment labs. You've worked on diagnostics, vaccines, and therapeutics. What kind of advice would you give to people who have the same commitment to prevention and yet to be able to combine the really disparate entities that are involved. So you've got academia, you've got your basic lab, you've got industry, you've got international organizations like WHO, CEPI now, for example. What's the best way for somebody to find their place in the world, to be able to make their contribution, whether they want to stay at the basic science level or to try to bring together these different elements to work together?
I think one needs to focus on what's most important at play, which is how can you help? How can you contribute in a really in a way that is and it's very hard when you're starting. In a way that is not about you, it's not about your work, it's not even about your next paper, it's not about your next funding. So that's where it's very hard when you start, because you are somehow competing for funding and for publication. But how can you, from the bottom of your heart, really find ways to help and to contribute to help others, which includes any scientist, any clinician, it doesn't matter where they're from, especially the local, of course, to focus your work on collaborating and helping others to solve the issues. There is always problems. There's work for everybody. That's not the difficulties it's not to find work. I think it's really that. And I think when you have a genuine approach to this, and you really are trying to help, and you do help others, people realize it. And then of course they want to work with you again. You are achieving important task, even if it's not for your career. But everything then comes back, and everything, the opportunities are there. So to me, this is what I've learned from all this, is to put your own self aside and just go for it. It's very hard sometimes, again, because you will be applying for the next grant and you will be needing those papers. And I know that reality. But again, it comes in due time. And actually, this is a question I really wanted to ask you. When you think about all the years you've been working, what is now your perception of, competition is not necessarily bad either. It's motivating people. It's a different concept. I personally myself prefer to collaborate. I'll tell you right away the answer. So for you, with looking back, how do you position yourself on competition versus collaboration, which is also a big topic right now among scientists in all ways anyway, and the need to collaborate, but also the need to get your work done and to publish and to apply for a grant. And so how do you see this now?
All right, touche. That's a great question, but thank you for your inspiring answer. And I certainly hope that everyone watching this will see how important your work has been for the world, and you brought to it this selflessness and this view of what can you contribute. I think that you are addressing a really key point here: competition versus collaboration. And I guess what I would say is that I don't think it has to be either or. I think the key element of competition that is helpful is what helps us strive to make, oh, I am so sorry about this telephone thing here. What helps us strive to be better, that to me is the good aspect of competition. It's not the being against another person. It's, if I feel competitive, what does that mean that I need to myself do to try harder, to work harder? And that's when I think this whole issue of collaboration is so crucial, because in fact, a lot of the key developments that have come out in science have been from people who were in orthogonal fields who came together. People who actually, for example, understanding the T cell receptor, it was a biophysicist and a biochemist who also then understood immunology and worked in immunology. I think that that's important. If you look at, say, the mRNA vaccines, it wasn't simply mRNA scientists, it was also the biochemists who developed the lipid nanoparticles, because otherwise the mRNA wouldn't be stable enough to be used. And so it really is not just collaboration within your own field, but it's actually collaboration between scientists within different fields. And so I think that that's how you take the good parts of competition and you combine it with the real collaboration and viewing outside your own, area of expertise. So I'd like to thank you for that. This has really been a fun discussion for me, and I think it's going to be very useful for all the attendees at the ISV Congress. So thank you.
so
And
much.
I just want to point out to the listeners that Dr. Kobinger is going to actually be the chairperson for the next Congress in 2022 as well.
That's right.
So we look forward to that being another excellent ISV Congress. Thank
Yes,
you.
and looking forward to seeing you all there.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.